I'm very, very excited to be introducing our Fireside Chat. I want to first, though, welcome, I'm not sure if people in the audience are aware that we now are joined globally by many other members and their guests as we're live streaming this last session. So I welcome our additional guests to our meeting today and really applaud this opportunity to hear for the first time at the National Forum from our Surgeon General of the United States. I'm going to just do a brief introduction of Dr. Phillips, who will be leading this chat, and then she will introduce the Surgeon General. But let me take a moment to say that it is obviously a great honor to welcome our Surgeon General and Dr. Phillip. Most importantly, I want to share with you that it's been an amazing opportunity to see these two public health leaders and the work that they have done as state health officials leading in both Indiana and Florida. So it's a just amazing opportunity. We're going to learn a lot from you today, I know. So with that, I want to introduce in particular Dr. Phillip, who will encourage our chat, although I can't imagine that will be too hard with Dr. Adams. But for many of you that may not have had the opportunity to meet Dr. Phillip, she has actually had an enormous background, having worked at CDC as an epidemiological intelligence officer. She also then worked in 3 counties at the county level in Florida, and now joins us for over a year as the Surgeon General and Secretary of Health for Florida. So she has had many challenges already facing her. And with that, Dr. Phillip, I'll turn this over to you to introduce our Surgeon General.
I'm sorry. Thank you, Sharon, and thank you so much for the opportunity to be at this meeting, Okay. It is indeed quite the opportunity for me to be here. This is my first meeting as a board member for the National Forum, and I have the distinct honor to interview someone I consider a public health friend and colleague, our new U.S. Surgeon General, Dr. Jerome Adams. So I will speak a little bit about his expertise and his experience at the state level, which I will tell you, for those of us in public health, it warms our hearts to see someone who has that background now serving as America's doctor. Dr. Adams is an anesthesiologist, which is somewhat unique in the role of a state health officer, and also has a background in public health as an MPH as well. And I think that uniquely positioned him to be at the helm in Indiana when their state experienced an unprecedented HIV epidemic. Through that experience, the rest of us watched and learned, and as we are now, every state dealing with the opioid epidemic that is seen nationally as well as within so many communities, I know that is another area that we will look to you for your leadership. On September 5th, 2017, Dr. Adams was sworn in as U.S. Surgeon General, and we look forward to supporting you in this new role.
Thank you so much. Here. It's a pleasure to be here. Thank you all for the opportunity to address you today. I think the work that you're doing here is so incredibly important, and I think most of you all were in the room earlier when I did my photobomb, but this issue is so important to me personally, having many family members who have suffered from cardiovascular disease and stroke. It's an issue that touches all of us. I won't ask, but I guarantee you if I did ask, every single one of you, if I asked who's been affected by this, every single one of you would raise your hand. Was actually in the car ride over today and told my driver where we were going, And I asked him if he'd been affected, and he said, my sister is in the intensive care unit right now, just got extubated. She was in a coma, had a huge stroke just a week ago. And so it's an issue that's very, very poignant, very timely because of the data you saw earlier, something that touches each and every one of us. So thank you for your work, because really my job as Surgeon General is to be a trumpet for the music that you all are creating together, to push it out and to try to connect folks and lower barriers. But ultimately, you're the ones that are doing the work, and I just want to make sure I'm partnering with all of you all in a way that helps lift up what's going on and helps us ultimately turn the tide on this epidemic that is cardiovascular disease and stroke. We talk about infectious disease epidemics. We talk about opioid epidemics, but we know more people are dying each and every day from these chronic diseases than are dying from communicable diseases and from the opioid epidemic. So it's not a either or, but we certainly want to make sure these issues aren't forgotten about.
Thank you. So I wanted to start out with a question about what it is to be Surgeon General. We all know the title, and actually I get asked this question a lot too, so I'm going to take notes based on what you say. What is it that you do, and you're still early on in this role, but what do you see as some of your priorities?
Well, thank you for that question, Celeste. And I think the most important thing for people to know is the Surgeon General is not a surgeon, does not have to be. There was actually an article last week saying, you get all kinds of weird stuff if you do Google searches for Surgeon General or do Google alerts. The article last week saying the Surgeon General needs to be a surgeon. They were upset that it wasn't a surgeon. The Surgeon General is also not a general. Actually, we use the Navy rankings, and so my title is actually Vice Admiral Adams. And so I'm not Surgeon Adams, I'm not General Adams, I'm Vice Admiral Adams. But in addition to, and I'm also not Attorney General. I get called that more than I get called Surgeon General. I do not want to be the Attorney General. I will leave that to Jeff Sessions. But there are a couple of important things that we do. There are a lot of important things that people think we do that we don't do. The Office of the Surgeon General has no program funding. So the only way that we get anything done is by partnering with other folks. We don't do regulations within the Office of the Surgeon General. We don't get involved in policy making to a large extent. There's no official role for policy making. It's all through influence. But one of the things that we do have is the power of the bully pulpit. So we get to communicate and try to enact culture change. And that's why I'm so honored to be here today and to speak with all of you all to help share what I think is important, but also to hear what you all think is important. The Office of the Surgeon General, the reason why I'm a Vice Admiral is I oversee the United States Public Health Service. And I see we've got one of our core members here in the audience. Can you introduce yourself to everyone?
Hi, Captain Kimberly Ellenberg, honored to be here. You have a great group, and you really bring people together. So, sir, this is a perfect place, crossroads.
Well, thank you so much for being here. We have over 6,700 highly qualified health professionals in the United States Public Health Service. Doctors, nurses, dentists, engineers, environmental health officers, and couldn't be more proud than to be the head of the United States Public Health Service, particularly at a time such as this. So whenever you see someone in uniform, in one of these uniforms at a health event, it's someone from the United States Public Health Service, embedded in FDA, embedded in Bureau of Prisons, embedded in CDC, all throughout the nation. And then I do get invited to policy discussions. That depends on the administration and the need. Right now, we're really leaning in on the opioid epidemic, and I think that is an opportunity and a challenge for you all. I think it's a real challenge because folks, again, aren't paying attention to chronic disease. I think it's an opportunity because many of the factors that led to the opioid epidemic, many of the social determinants, many of the community factors also are the same ones that lead to cardiovascular disease and stroke. And so if we address the one, we will address the other, especially if we look upstream. As far as the priorities for the office, the Department of Health and Human Services has 3 clinical priorities: serious mental illness, childhood obesity, and the opioid epidemic. Beyond that, I want to make my tenure as Surgeon General be all about partnerships. And my motto is better health through better partnerships. I think that for far too long, we've been speaking to each other, living in our silos. I say, you've heard the phrase, preaching to the choir. Well, we're preaching to the other preachers when we come to most of our meetings. You look around the room, and how often do you have the business community? How often do you have the law enforcement community? How often do you have the Department of Defense in the room? Not very. But I'm really proud to say that you all had all those people in the room here today, and I think we need to do more of that. And that's going to be my big push during my time as Surgeon General, because I think if we can become better partners and better communicators, because part of being a good partner is learning what your partner's needs are and communicating to them in a way that resonates. If we can be better partners and better communicate, then it's not going to matter if it's cardiovascular disease or stroke. It's not going to matter if it's the opioid epidemic. It's not going to matter what the disease is that we're focused on. We're ultimately going to be able to bring the right people to the table to change outcomes.
I'm so glad you recognized Captain Ellenberg. I had a chance to meet with her last night. She was actually deployed to Florida to assist in our hurricane response to Hurricane Irma. And I know briefly we got a chance to chat before this conversation, and you shared with me during your first few weeks, you didn't anticipate in your role as U.S. Surgeon General that you would be involved in hurricane response. So I was wondering if you could share with our group what that was like for you, and also recognizing how important from a state perspective, having the ability to call on federal partners is in our response.
Well, I'd love to address that. I think it's why it's so important that you all make sure you're bringing in your local public health officials, your state health officials, your county, your local health officials into the conversation when you're having them, because it's easy for us to get distracted. I came in as Health Commissioner of Indiana right in the middle of Ebola. You came in as Surgeon General of Florida in the middle of Zika, or right in the beginning of Zika, and really had to deal with that. It's easy for us to get distracted, and it's important that all of you all continue to keep us engaged as health officials so that we can be on the same page. Surgeon General, I never expected I'd spend the first 4 weeks on my job engrossed in hurricane response. It's something that I'm very, very proud of. It's allowed me the opportunity to quickly get up to speed with many of the partners that we're going to have to work with within HHS. And to be honest with you, I'm probably better equipped to, again, talk to folks about cardiovascular disease and stroke now because I know the partners because of the hurricane response that we had to put in place. Spent about a week in Puerto Rico on the U.S. Virgin Islands, and it's just, it's hard to describe. I've seen many disasters. I talked to folks who'd responded to different disasters. The best I can describe it has been the tornado situations that have been affected by, or communities that have been affected by tornadoes. It's usually just a swath of damage. I've been to places that have been affected by forest fires. I've been down the Gatlinburg. You still can see the beginning and the end of where the forest fire hit Gatlinburg, Tennessee. You go across the island of Puerto Rico, the U.S. Virgin Islands, the entire island is decimated. I've never seen anything like it before. And you also have to consider you never want to compare tragedies because any situation where life is lost, where people are losing things, is bad, whether it's 1 or 1,000 or 1 million. They're all bad. But on the continental U.S., at its worst, we can still put people in a bus and drive them 2 hours, and they can have a warm bed, they can have hot food, they can have water, they can have communication, they can have electricity. You had this situation occur on an island. There was no putting people on a bus and sending them out. And then you look at response and recovery. On the back end, you could bring in power poles. You could bring in utility workers. You could bring in folks into other areas to help respond and rebuild. again, that's a situation that just isn't an option in Puerto Rico and the U.S. Virgin Islands unless you're putting something on a barge and then sending it out. And folks also forget it's still hurricane season. So we're trying to send help, and in many cases, because of the 3 hurricanes that occurred in a row, we'd get help ready to go and then have to hit the brakes and say, whoa, we can't send out our emergency workers for Irma when we see Maria's right on the horizon. And folks don't realize all the challenges that exist there. But what I was most impressed with was the desire to rebuild. The folks there were hurt. They were down, but they were not out. They were determined to rise again. And the one thing that they asked me to tell you all and to tell everyone here in the continental U.S. is that they are our American brothers and sisters. Shocking to me that almost half of the people in the United States don't realize Puerto Rico is part of the United States. They are our American brothers and sisters, and we need to think of them as such and treat them the way we would treat any other American citizen. And I can guarantee you from the Office of the Surgeon General and the Department of Health and Human Services that we will be there with them until we get them back up to speed and where we know that they need to be in order to prosper.
And I can tell you from the state view, we could not do it without all of our federal partners. So we want to thank you for your leadership and for all of your officers that were a part of the response in Florida and Texas and certainly in Puerto Rico. So thank you.
We had over 900 Corps members respond as part of the Irma and Maria responses. We've got about 200 on the ground right now, and that's in addition to FEMA and in addition to DOD. The other thing that struck me is that folks have said they've not seen such camaraderie in a response before. It's never going to be as fast as we want it to be, because anytime people are suffering, the relief is never as fast as we want it to be. But we're dedicated, we're committed to making sure we do right by, again, our American brothers and sisters in Puerto Rico and the U.S. Virgin Islands, as well as in Texas and as well as in Houston, because that's the other problem is you shift from one thing to another and you forget about the people who were suffering just last week, who we were paying attention to.
In Florida, we emphasize everyone having your emergency kits ready to go, which includes medications if you have chronic diseases. And we have found that sometimes 3 to 7 days, depending on the nature of a storm, may not be enough. It's certainly challenged our ability to plan for the next storm, to think bigger. I think that's another reason for emphasizing how important prevention is, and the fact that we know that there is so much that we can do, primary, secondary, tertiary prevention. So, and I appreciate you commenting that this was an opportunity for you to meet a lot of different partners so that you can talk about some of this other work that impacts so many thousands, hundreds of thousands of lives. So if you could speak to some of the activities that you see going forward around heart disease prevention.
Well, exactly, and I'm so glad you mentioned that, because one of the biggest challenges that we had and continue to have in response to the hurricanes is actually dealing with people who have chronic disease. One of our huge endeavors was making sure we could properly care for, and ultimately we ended up evacuating several hundred people for dialysis services. My big concern in the few weeks ago that I was there were the people who had been off of their hypertensive medications, their diabetes medications for several weeks as part of the response. And we partnered quite a bit with the pharmacies and the pharmacists there, sent several pharmacists there to help respond. And we know that these are things that we're trying to ramp up as part of a response, but that we should have been doing all along anyway. We should have been partnering with the pharmacies and the pharmacists to make sure folks had the proper medications and had access to them. And to your point about prevention, you start to ask the question, why was the burden so huge on Puerto Rico and the U.S. Virgin Islands in the first place from chronic disease? Ultimately, if we could get further upstream and lessen the number of people who are in need of these medications and these services, then the impact wouldn't have been so severe when you have an unexpected disaster like a hurricane strike. So it all ties back into one another, and I think it's important, again, that we use the opportunity there to talk about the importance of prevention, both of chronic disease and of the sequelae of chronic disease that can be exacerbated when folks have something else happen to them. We want to build, ultimately, resiliency, and that's a buzzword now, but it's something that I'm really invested in, particularly when you look at disparities. The community, getting a diagnosis of hypertension shouldn't be a death sentence. It shouldn't mean that you end up having your leg amputated. It shouldn't mean that you end up in an intensive care unit with a stroke further on down the road. But some communities have more resilience built into them than others, and one of the things we need to do is reach out to non-traditional partners and help build that resiliency. I want to bridge a little bit now into my Better Health Through Better Partnerships initiative. You heard from Dexter Sherney earlier, Dr. Sherney. They're doing it right in Columbus, Indiana, through a lot of the leadership that he initiated. But we've got to show the business community that caring about health is integral to their bottom line. We've got to show them that, and I'm convinced that we can show them that it's integral to their bottom line. I'm convinced that health and prosperity are directly linked, and the communities that are more prosperous are more healthy, and it becomes a positive cycle, and the communities that are less prosperous are less healthy, and it becomes a vicious downward cycle. If we want to build up communities, bring jobs in, we've got to show businesses that they need to invest in complete streets so that people can walk, so that ultimately they won't end up with cardiovascular disease and stroke. We've got to show businesses that they've got to lean into anti-smoking campaigns, because that's going to lead to healthier workers and, again, a more prosperous community. And if we do that, then ultimately that will lead to more, to fewer people with cardiovascular disease and stroke. We've got to move beyond our traditional messaging about healthcare outcomes. Remember what I said about preaching to the choir. We've got to change our message. When we talk to the business community, we can't say, we want you to care about cardiovascular disease and stroke. We've got to say, we care about your bottom line, and here are some programs we've got that will help your bottom line. We can't go to the superintendent of the school and say, we need you to care about cardiovascular disease and stroke. We've got to go to them and say, we've got a great program that's going to raise your test scores. Simply giving students 10 minutes of physical activity will raise your test scores. Guess what? It'll also lower your risk of cardiovascular disease and stroke. You heard earlier from the chairman of the Joint Chiefs of Staff. Reframing health in terms of a security issue is something that I think we can do. He probably mentioned this earlier, but did you know that 71% of 18 to 25-year-olds are ineligible for military service? So instead of going to the military and saying, we need you to help us prevent cardiovascular disease and stroke, we can go to the military and say, we've got programs and we want to partner to make your country more safe and more secure. And you've already got an army, no pun intended, of National Guardsmen, of uniformed services folks all throughout the country who then we can recruit to help us do the things that we know will prevent cardiovascular disease and stroke. But you've got to invite them to the table. I'm sorry, I'm filibustering here.
No, but it was almost like you were at the meeting today, because I think what you're saying, the panelists spoke to some of those themes about broader partnerships, having at the table businesses, payers, plans, large hospital systems. And I think we are starting to see that shift and that understanding that we all have to row together. Based on your comments and the direction that you think we need to move in, are there certain programs, activities within HHS that the members of the partnership can think about better, knowing more about tapping into and using that as a way to expand what we're doing?
Well, I was hoping you were going to ask me that. I've got a list of a few programs. I actually talked to the director of the Office of Minority Health yesterday and wanted me to make sure you all know that they awarded over $5 million in grants for the Empowered Communities for a Healthier Nation initiative. And 8 out of 15 of those grants will address obesity. And so that's one place where we're leaning in. The National Heart, Lung, and Blood Institute is funding research into childhood obesity. The Planned Primary Care Pediatrics Learning Activity and Nutrition Trial is a multi-site trial testing the effectiveness of family-based weight loss intervention for obese and overweight children. And I'm really excited about that because we're too disease-centric instead of health-centric. But secondly, we take disease and then we look at the individual. How do we bring in the family? How do we bring in the community? How do we ultimately wrap an environment around every single American citizen that is conducive to health? And so programs that can bring everyone else in are so important. National Institutes of Health also participates in the National Collaborative on Childhood Obesity Research. The Office of Disease Prevention and Health Promotion is under HHS, and we put out the dietary guidelines for Americans and certainly want to work with you all on that. I'm passionate about better eating, but as a father of 3 young children, I'll tell you it's hard. It is hard. My 11-year-old, and I probably shouldn't say this while it's being recorded, but my 11-year-old probably hasn't had a full serving of vegetables in, well, longer than what I want to say. It's hard, and as a father, I know how hard it is, but trying to make sure we can find out ways to incorporate healthier diets into the environment and acceptance of that. The Office of Disease Prevention and Health Promotion also puts out the physical activity guidelines. The second edition is going to be released in 2018. One of the things that I want to do as Surgeon General, so again, I'm a Vice Admiral. The uniformed services all take a physical fitness test. A lot of times the officers, the people in the nice uniforms, they take a pass on those physical activity tests. Well, I plan on taking the physical fitness test. I plan on passing it and hopefully doing quite well on it, but then using that as a launching pad to go into communities and talk about childhood obesity, again, in concert with our uniformed services officers. The test looks at flexibility, cardiovascular endurance, upper body endurance, and core endurance. Well, that's to have a baseline level of physical fitness to be in the military and protect our country. But every single one of us should have a baseline level of fitness on those parameters, and every single one of our children should have a baseline level of fitness on those parameters. And I'm looking at Dexter shaking his head again. Every worker for a company that has a baseline level of fitness on those parameters is going to be more productive, is going to have less absenteeism, is going to be present more when they're in the workplace. If we do these things, they're all going to feed back into, again, a more healthy and a more prosperous society. Across agencies, CDC supports comprehensive tobacco programs in all 50 states. You all know that. Health and Human Services Interagency Council on Smoking and Health is one that I'm a part of, and we're trying to coordinate activities on smoking. That's an area where I'm worried we're going to start to see turnarounds. I really am worried about smoking, and the Office of the Surgeon General has put out reports on smoking before. We will continue to have that as a priority of our office, but I'm worried about the transition between vaping and e-cigarettes and combustible tobacco. And I think you all need to be a part of that conversation there. The one thing we have is the opportunity to get involved early. We didn't have that with combustible tobacco. Combustible tobacco had already taken a hold on our society before we even recognized that it was a danger. I have pictures around my house. I love classic photos and publications, and people think it's odd. I've got pictures in my or advertisements in my house from old magazines of doctors smoking. Mm-hmm. We didn't even accept that it was a problem. We have an opportunity now to get in on the ground level in terms of e-cigarettes, and I think we really do need to think about that. The other thing about e-cigarettes, and again going back to disparities, is we're seeing the numbers go down in terms of smoking combustible cigarettes, but the problem is they're going down quicker for more affluent communities than they are for poorer communities. And that's a challenge that we have in public health. We can look at the whole and put in programs that help the whole, but at the same time worsen disparities if we aren't careful. And so I encourage you to always be thinking about health equity and making sure programs are available for everyone in the community and are tailored to and are helping everyone in the community equally when you put them in place, and not just saying, hey, we're doing a good job and patting ourselves on the back because the overall numbers are going down.
So thank you for not challenging me to like a push-up contest or something. When you started talking about that, I was wondering where you were going.
I do that in the schools that I go into, and there's pictures on the internet of me in my suit and bow tie doing push-ups with elementary school gym class. So, you know, we've got to walk the talk.
See, I didn't know that, but I'm not surprised by that. So we now have over 90 members that are part of the National Forum, and many of them are here, probably many of them are watching online, and hosts of other folks. What would your ask be to us in terms of how we move forward the agenda that you outlined, if there are specific priorities that you see for the members here?
My challenge to you all would be, each and every one of you, when you go home, think of one non-traditional partner. And you may have learned about a non-traditional partner today. The advantage that you have is now you have seen that someone else could do it. Whether it's going home and talking to your neighbor, whether it's going home and finding the National Guard unit in your community, whether it's talking to the law enforcement community. And there's a great program that I learned about when I got my MPH over 20 years ago at UC Berkeley, where they were trying to get moms. Berkeley it has the distinction of having some of the greatest health disparities in the country, because you've got the really affluent hills of Berkeley, California, that butt up right next to the really poor communities of Oakland. And we were trying to figure out why we couldn't get folks to exercise. We'd put in the education. We'd put in the programs. Did focus groups and found out that folks were scared to go out and walk in their communities, scared they were going to get shot, scared they were going to get mugged. And they instituted a walk with a police officer program, partnering with law enforcement. The moms in the community in particular, but the moms, the kids, a lot of folks really got into that program. They were healthier. The police officers were healthier. And it fostered the relationship between the community and the police, which, as we know right now, can be pretty strained in some of these areas. It was a relationship that really helped ultimately lower people's risk of cardiovascular disease and stroke, to what we're talking about today, but also helped in any number of other ways. But how many of you all would think that when we're talking about cardiovascular disease and stroke that we need to invite the local sheriff to the table? And so my challenge to you all is, again, think of at least one non-traditional partner that when you go home, you can reach out to them. The business community, the local person in the community. Think of the number one employer in the community and say, hey, and here's the challenge again about the business community and all these other folks is you can't frame it in terms of what you want. People, employers, stroke, heart attacks, that's so far down the road for them, and frequently those folks are on Medicare by the time that cost comes up. They don't care. I don't want to say they don't care, but they're not going to prioritize your ask. You've got to help them see how you can increase their productivity, increase their prosperity, and if you do that, when you engage those partners, get that partner and then figure out how you can engage them and show them how you can help them achieve their goals, and then guess what? You'll achieve your goals too. You'll have a new partner, and you'll have new ways to get at something that we've been trying to get at for years, and that, again, we're seeing go in the wrong direction.
You've spoken on disparities, and I know part of your previous life was trying to encourage more diversity within anesthesiology, and I would assume physicians in general. In this role, and I can tell you my own experience, I've had young people come up to me and say, seeing you in that position makes me feel like I can do it. I'm sure you've heard that a lot already. Can you share some advice to young people, particularly young people of color, regarding if they're interested in a career in health but feel like they can't do it? What words of advice do you have to them?
Well, I'll start off with word of advice to them. Yes, you can do it. Absolutely. And one of the things I try to do is share my story. No one in my family was a physician or had an advanced degree. We grew up eating the proverbial government cheese. We were poor. We had 5 kids in the family. I had every excuse not to. I have a brother right now who's incarcerated. I have a sister who's diabetic. I have every excuse in the world not to do it. But the more we all can share those stories of people who were able to prosper, I think the more it allows folks to see that, yes, I can succeed. But that said, when I was in medical school, and you can attest to this too, I noticed a big difference in the opportunities, the doors that were open to different groups of people, to the mentorship and the sponsorship that different groups of people had. So speaking to all of you all, my challenge to you all is to find someone who may not have had those opportunities and to be a mentor to them, to be a sponsor to them, to encourage them to do the right things, and to show them that it's possible for them to be able to achieve so much more. I think the other thing that we've got to do across the board, and we were talking about the push-ups with the kids. We've got to walk the talk. Kids don't care what you say, they care what you do. And as a dad, I can tell you that. I can tell my kids all I want: to eat vegetables, to exercise, to stay away from drugs. But if they don't see me modeling that behavior, then it's not going to mean anything to them. And so again, that ties in with mentorship and sponsorship, but being a good example for folks. Those are partners who you can reach out to in your communities. The local youth groups, they have a tremendous reach and ability to amplify your message if you can get just 1 or 2 key kids in your community to embrace your message. And the other thing we've got to do is, it goes back to communication. We've got to figure out how to talk to them. We are doing a terrible job of communicating in the health and public health communities, again, because we speak in our language and not in theirs. Ultimately, we're all here talking about communication and marketing. The data it's bad, but it's been bad. We know the data. It's not changing. We know the programs that work, the basic things to do: eat better, move more, don't smoke. Our problem is a marketing problem. Well, guess what? They can figure out exactly which kid wants the double stuffed Oreo and what time they get home from school and what kind of commercial with what colors in that commercial are going to reach that particular person and convince them to buy their product. It's already out there. We need to be better communicators and figure out how to better market our message, particularly to young people, about health and wellness and how it will lead them to an ultimate goal or endpoint that they want to get to. And I think if we can do that, we will recruit them into our army, and they will be not just healthier themselves, but be a group of people we can rely on to help push our message out.
Well, that was my last question, and that was perfect. On behalf of the National Forum, I want to say congratulations.
Thank you.
Thank you for your leadership. We look forward to working with you, supporting your priorities and your agenda, and making progress together. On behalf
of the Office of the Surgeon General and the Department of Health and Human Services, I want to say congratulations to you all for this convening. And the next time you have it, I want to see more than one mayor. I want to see more than one person from the uniformed services community. I want to see more non-traditional partners here so that, again, we can cross-pollinate and truly achieve better health through better partnerships. Thank you for the opportunity.
Thank you, Dr.
Absolutely. Thank you all. Tell my wife I kissed Celeste.
Streaming?
Yes. So while Dr. Phillip and Dr. Adams stay here, I just want to very quickly make a few essential comments. Everybody knows that you can't save the world if you can't pay the rent, and you can't put on a meeting if you can't pay for it. So we're very grateful to the sponsors of our annual meeting who appear on this sign and others. I want to make sure I don't omit anyone. So Novartis, Sanofi Regeneron and AstraZeneca are silver sponsors. Boston Scientific, the Close the Gap program, is bronze sponsor. And the American Heart Association very generously provided a very heart-healthy breakfast this morning. So thank you all for that. Now, in the Treasurer's report, Laura Gordon commented on how we're a low overhead, frugal operation, and that is evident even here today in this meeting, or carries into it, because we are blessed to have a lot of volunteers who help keep the trains running on time in this meeting. So I want to thank Soni Dodani, who is a member who's been helping take notes, and then Jennifer Banner is, Virginia Howard, where's Virginia was over there? Oh, there's Virginia. Yep, thank you. Jill Seitlin, April Wallace, and Julia Schneider for your help all throughout the day and even in the preparation for it. I feel like I have one of the greatest jobs around because, one, I get to interact with you all, which is, it really is gratifying for me. And I feel really privileged to have the board of directors, not because you're my bosses, but the board of directors that the National Forum has. It's one of the things, these volunteer leaders are one of the things that attracted me to the National Forum 5 years ago. It's really a privilege. I learned so much from your wisdom, from your insights. So you've seen and heard from, I think, nearly all of our board members today, throughout the day. So why don't you all stand up, please, one last time. And our volunteers and the board members, please. Thank you for everything you do. Thank you, of course, to everyone who's here, because you are the National Forum. It's our National Forum. And finally, everybody here knows that in addition to not being able to save the world if you can't pay the rent, you also can't pull off a meeting this energetic and this dynamic without some really great hard work going on behind the curtain, right? So let's pull the curtain back. Thank Mary Jo Garofoli. Debbie Martinez. And I think when anyone thinks of the National Forum, the first image that comes to their mind is Julie Harville. Thank you, Julie. And finally, to me, one of the cool things about this meeting is the people it brings together. And I could give any number of examples from our friends here in the room. But I want to think back to when I first met Dr. Adams. And is Janet still here? Okay, so Sharon Moffat and ASTO had pulled together a Million Hearts ASTO Learning Collaborative. And I think in the second year, Indiana, the State Department of Health was one of the participants. And you all know state health officials they're very busy people. They have very big portfolios, right? You two know it better than almost anyone. So it's not surprising, it's not unusual in a meeting like that to have the state health official come with his or her team and come in at certain times and be out of the room at other times. This is a two-day really intense workshop on Million Hearts, on preventing cardiovascular disease, what we're here for, on bridging clinical health and public health. And I was so impressed that when other health officials were coming in and out of the room, that was not Dr. Adams. Dr. Adams was there for every bit of it, leaning in the whole way. And I think that and his appearance here today, sharing his time with us and his agenda is indicative of his commitment to the work that we do. So Now we have him in our boat rowing the same direction. Thank you.